Goedemiddag, mijn naam is Esther Schwarz en ik zal jullie graag mijn klinische les willen voorstellen. Voordat ik begin wil ik graag zeggen heel erg bedankt voor deze mogelijkheid dat ik deze presentatie mag doen. Ik heb van deze klinische les en van deze casus heel veel geleerd en ik hoop dat ik jullie ook iets kan van meegeven. Het is even belangrijk van tevoren te zeggen dat ik mijn zeemeerarts in Oldenburg heb gedaan in Duitsland en ik daarom mijn klinische les ook in het Engels heb geschreven. Dus ik zal mijn presentatie nu ook op het Engels doen. Dus als jullie vragen hebben op een latere tijdstip, kunnen jullie me ook altijd een e-mail sturen in het Nederlands of vragen stellen. Maar voor nu zal ik mijn presentatie in het Engels houden. Oké. My clinical case study was about a patient with jaundice as the first presenting symptom of heart failure. I would like to talk about the case first, and then I will explain a little bit about the cardiomyopathic syndrome, and in the end I would like to go through some of my learning points. Okay, so we met Mrs. Jefferson. Of course, that's not her real name. We named her just this for the case. We met Mrs. Jefferson in the emergency department in the clinical in Oldenburg. And she was a 74-year-old lady. She was very strict and very well-to-do. She knew what she wanted. And she was not very fond of doctors. She was very critical of doctors and hasn't been visited to the GP for quite some time. But she came to the emergency department presenting mainly with progressive worsening symptoms of diarrhea and vomiting for 2 weeks. And she felt exhausted, also for a little bit longer now already. But she was mainly referred from the GP because he saw jaundice. So a yellow discoloration of her skin as well as of her sclera. She mainly went to the GP because of the diarrhea and vomiting, and that was the only reason. She didn't feel like she actually wanted to go there. She lived at home, she was retired, and she lived together with her husband and her son, who took good care of her. Before I continue, it is important to know that because of the diarrhea and the vomiting, Mrs. Jefferson was put in an isolation room, so she was on her own, and we could only enter the room with protective gear to prevent the spreads of viruses such as the norovirus. Yes, so what did we know about Mrs. Jefferson? Since she hasn't been to the GP and didn't really like going to the GP, there were no known previous medical conditions. She was also not drinking any alcohol, but she was smoking. She was smoking nicotine quite a lot. There were no other cardiovascular risk factors though. In the Tractus anamnesis, besides the vomiting and the diarrhea, she was talking about coughing, which was dry and which was already constantly a companion of hers for the last 10 years. She was also describing a bit of a loss of appetite for the last 2 years, but no cardiac symptoms. And yeah, no other symptoms. On physical examinations, our main findings were that she was tachycard, and we clearly saw the visible yellow-colored sclera as well as the mildly colored yellow skin. We also saw signs of dehydration with dry mucus and turgor, and she described slight epigastric tenderness and abdominal palpitation. Other than that, we didn't see any abnormalities in the vital parameters. Okay, so our first focus was the jaundice, which is the yellowish tissue discoloration caused by an accumulation of bilirubin deposits. This hyperbilirubinemia can be caused by the prehepatic, intrahepatic, or posthepatic causes, and can be differentiated into unconjugated and conjugated hyperbilirubinemia. In this case, in Mrs. Jefferson's case, it was a conjugated hyperbilirubinemia, which is caused by intrahepatic and extrahepatic causes. For example, liver cirrhosis, hepatitis, primary biliary cholangitis, sepsis, infiltratory process of the liver parenchyma, but also cholestasis due to, for example, biliary obstructions or cholelithiasis. Yes, if we look back, those are the laboratory findings. We also saw that there's an elevated infection parameter, and other than that, we also saw elevated liver function parameters. Okay, if we look back to the monastic, to the history taking we have done, we see that she did not drink a lot. She didn't have an excessive alcohol abuse or anything. She did not take any medication. There were no hepatitis risk factors. She had normal temperature and no change in stool color or any postprandial epigastric pain or biliary colic, which would have made biliary obstruction more likely. For example, through like a gallbladder stone or something. The physical examination, we didn't see any signs of chronic liver failure or portal hypertension, and we also didn't palpate any enlarged gallbladder. That she didn't drink or that she didn't take any medication also makes liver cirrhosis less likely, and since she didn't have any hepatitis risk factors and normal temperature, it also made hepatitis or an inflammatory process less likely. Okay, then we did an abdominal ultrasound just to check if there's any changes in the liver parenchyma or if there's any abnormal anatomical structures, or if we see stones, for example, or tumors. None of this was the case. However, we did see extended liver veins and an extended inferior vena cava with no physiological change of the parameter of the inferior vena cava during an expiration. You see here on this picture on the left, you see the heart, and you see the vena cava completely collapsed. And here you see an extended inferior vena cava, which, I mean, it's not a video, but in our case, in Mrs. Jefferson's case, it was not collapsible. We also saw pleural effusions on the right side, and this led us to believe that she had a congested liver. Pleural effusion and congested liver are a sign of heart failure. So we had to do a complete reconsideration of our case. We are now seeing a woman who has a congested liver and pleural effusion, so we should focus on the cardiac condition as well. The main causes for heart failure are coronary artery diseases, hypertension, pericarditis, cardiomyopathies, but also arrhythmias or valve disorders. And if you remember in the beginning, she didn't mention any cardiac symptoms. No dyspnea, which is very important. She didn't have any peripheral edema. She didn't have any dizziness or palpitations. There was no indication for a cardiac problem. But because there was an indication for heart failure, we of course did the whole cardiac diagnostic. First we did an ECG, which showed a left bundle branch block. In case that the left bundle branch block is new, then this could mean that she has an acute coronary syndrome. In the laboratory results, we saw elevated acute and chronic heart enzymes. And the most striking thing we saw was in the echocardiography. Here on the left, you see an echocardiography, which is not the one of Mrs. Jefferson, but it's very telling, I think. So what we saw was an almost akinetic heart with global restricted systolic function. The right and left ventricle was completely dilated. The left ventricle systolic ejection fraction was around 15%. With a normal, it would be 55%. So it was really low. And she had insufficiency in the tricuspidal and mitral valve. Here in the video, you can see on the left the normal the good pumping function of the heart, and on the right, the poor pumping function of the heart. Well, since she clearly had such a poor functioning of the heart, we did a percutane coronary intervention, and it showed that she had an extensive 3-vessel coronary artery disease.
Ventricular walls, and the ventricular walls are not contracting strongly. When looking at systolic function, we want to do it globally, meaning that we want to make sure that we look at all the important structures, such as the mitral valve, the septal and inferior wall contractility, as well as the left ventricle chamber size change during the cardiac cycle. The reason this is important is because if those structures are damaged, then they can't be used for visually assessing systolic function. For example, if a patient has mitral stenosis, then the leaflets of the valve might not hit the ventricular wall. Another example would be a patient with a previous MI. They could have focal damage to the myocardium, producing weak contractility in that left ventricle region. Both of these instances could be interpreted as poor systolic function, but this would be a false positive. Lastly, even though the systolic function can appear normal, the patient can still have acute heart failure. 50% of patients that have acute heart failure have normal systolic function.
Yes, so that led us to the conclusion that Mrs. Jefferson had a heart failure caused by a silent 3-vessel coronary artery disease with reduced ejection fraction and cardiac decompensation, including pleural effusion and a congested hepatopathy. The interaction between heart failure and liver dysfunction is actually quite common. Normally the liver dysfunction is silent, though, and asymptomatic, and is only seen in the laboratory results. If a liver dysfunction is involved, it is connected to poorer outcomes. The clinical picture is mostly dominated by right-sided heart failure symptoms, classically the dyspnea, but also fatigue, coughing, weight gain, and ankle edema. Jaundice is uncommon, and however, in literature described, it is always accompanied with dyspnea. It is never on its own, so in this case that was quite different than what the literature describes. The treatment and the prognostics always depend on the underlying cause of the heart failure. So, if we look at Mrs. Jefferson, she has a 3-vessel coronary artery disease. A lot of these arteries in the PCI showed that they were completely or until 90% blocked, and the ejection fraction was really low. So it is no wonder that after some time Mrs. Jefferson became hemodynamic and stable. She spent around 7 hours in the emergency ward with all the diagnostics and all the things that have been going on. And in the end, she went into the intensive care and had a cardiogenic shock and died of multi-organ failure 3 days later on the intensive care unit because we were too late to treat her. And the damage of the underlying disorder was too extensive. Yes, this is why I want to talk about treatment delay for a really short amount of time, because I'm already over time, I see this. There are 3 types of treatment delay, and I think this is one of the things I really took with me. One of them is the patient's own health-seeking behavior. She had a clear aversion to medical care and medical professionals, and it is likely that she had the acute coronary syndrome already 5 weeks previous when the exhaustion started, and that her heart has been pumping for quite some time and now it decompensated. The next treatment delay is not in the patient but in the medical professionals. The atypical presentation led us to first do a full diagnostic, abdominal diagnostic, but since she didn't present with any cardiac symptoms, we did not take a look at any cardiac issues. So that led us to the first misdirect in this case, and also led to a treatment delay in the end. The last part is about the institution. She's been put into contact isolations, and studies have shown that people in contact isolation are less or more likely to have substandard care, that they're not as often seen by medical professionals just due to the fact that they are in contact isolation. So it might have been that her clinical deterioration was recognized later than it could have been. So what are my learning points? I think, first of all, not every first presenting symptom is what it seems. We should keep a broad differential diagnosis, and I feel like we in the beginning completely focus on the jaundice, and we should always look broader and look into different differential diagnoses. Of course, this was an atypical case, so I think this is also something I take from this. I learned a lot about the cardiohepatic syndrome, and I also know from now on that if there's a combination of jaundice and dyspnea, that I will always lead to an extensive cardiological examination. And if I get the chance to do an ultrasound, to just also do, if we have the probes, to do an echocardiography, so that I don't miss any cardiac problems if I get the chance. I think in general, which also we should do, is encourage health-seeking behaviors, and always take a standardized approach, no matter if the patient is in contact isolation or not. Yes, I think those are my main learning goals. And yes, thank you for listening. And in the end, you still see my literature. And that's done. Thank you.